Welcome to This Week in Neurosurgery. This week we're covering 10 notable papers spanning pediatric cerebrospinal fluid management, advanced techniques in functional and spinal neurosurgery, and critical decision-making in geriatric trauma and neuro-oncology. Let's dive in. We begin in the field of pediatric neurosurgery, where 3 new publications address critical aspects of oncology, shunt infection, and hydrocephalus management. Writing in the Journal of Neurosurgery, Pediatrics, Krajewski and colleagues analyzed data from the prospective, multicenter EHIT 2000 trial, evaluating 291 pediatric patients with non-metastatic intracranial ependymoma across 71 centers. Central neuroradiological review was performed on postoperative imaging for 206 patients, revealing a gross total resection rate of 67%, while 33% had residual disease. Crucially, surgeons erroneously reported achieving a gross total resection in 11 out of 40 cases where residual disease was actually present on central review, with adhesions to the brainstem being the most common reason for leaving intentional residual tumor. When patients with residual disease underwent a second surgery as part of their primary treatment, gross total resection was achieved in nearly half of them after up to 3 procedures. Importantly, this second surgery did not increase the frequency of postoperative neurological deficits compared to those who had a gross total resection initially. The clinical payoff was substantial. A second surgery significantly improved 10-year progression-free survival to over 42%, compared to just 22% for those who did not undergo a repeat operation, while overall survival at 10 years was nearly 70% with gross total resection versus 51% with residual disease. Moving from pediatric oncology to cerebrospinal fluid management, a multicenter study from the Hydrocephalus Clinical Research Network, published in the Journal of Neurosurgery Pediatrics, provides much-needed clarity on the epidemiology of late cerebrospinal fluid shunt infections, defined as those occurring more than 6 months after surgery. Analyzing over 6,600 shunt procedures in patients under 18 years old, the investigators identified early infections in 4.3% of cases and late infections in 0.9%, meaning late infections accounted for nearly 17% of all shunt infections. The authors found that late infections are clinically distinct from early ones. They are significantly more likely to present with abdominal pseudocysts, occurring in 24% of late infections compared to less than 4% of early infections, and they are far less likely to be diagnosed via positive cerebrospinal fluid cultures. Furthermore, late infections were frequently preceded by secondary clinical events, such as abdominal surgeries in 21% of cases, shunt taps in 23%, and bacteremia in 9%. Clinicians treated late infections differently, using vancomycin less frequently, and opting for complete shunt removal in 65% of cases, compared to 88% for early infections. Despite these treatment differences, long-term shunt survival did not differ significantly between the early and late infection groups, highlighting the need for vigilant, long-term surveillance and tailored diagnostic strategies. In the same journal, Lai and colleagues address a long-standing debate in neonatal neurosurgery, the timing of intervention for progressive post-hemorrhagic ventricular dilatation in preterm infants. This international multi-center study of 170 preterm infants compared outcomes between early intervention centers, which intervened at lower ventricular indices, and late intervention centers. Infants managed at late intervention centers were more premature and had lower birth weights, with initial neurosurgical intervention occurring at a median of 31.5 days of life, compared to just 18 days in the early intervention group. While early intervention centers utilized lumbar punctures more frequently and had a lower overall rate of ventriculoperitoneal shunt insertion, 30% compared to 62% in late intervention centers, there was no statistically significant difference in postoperative surgical complication rates between the two strategies, which stood at 11% for early and 24% for late intervention. On multivariable analysis, the risk of surgical complications was driven entirely by lower gestational age and lower birth weight rather than the timing of the intervention itself, supporting cautious early cerebrospinal fluid diversion in these fragile, low birth weight infants. Next, we turn to functional neurosurgery and minimally invasive spine, where several new papers offer practical guidance for patient selection, procedural optimization, and recovery tracking. In the first study, Khalid and colleagues present a 24-year single-center experience with vagus nerve stimulation for refractory epilepsy in 356 patients. While vagus nerve stimulation is a well-established therapy, this study sought to identify which patient-specific factors predict a favorable response, defined as a 50% or greater reduction in seizure frequency. Surprisingly, patient age at implantation, sex, seizure etiology, and magnetic resonance imaging findings had no significant impact on efficacy. Instead, baseline seizure frequency was the primary predictor of success. Patients with a low baseline seizure frequency of only 1 to 2 seizures per year, or 1 to 2 per month, experienced the greatest benefit, showing significantly better outcomes and, in the case of the annual seizure group, a significant reduction in their anti-seizure medication burden. Meanwhile, Du and colleagues focused on optimizing percutaneous balloon compression for trigeminal neuralgia in another Journal of Neurosurgery paper. Utilizing a propensity score-matched analysis of 230 patients, the authors compared effective and ineffective treatments to build a highly discriminative, predictive model. They found that patient demographics did not influence outcomes. Instead, intraoperative physical parameters were the sole determinants of success. Specifically, the volume of the balloon, the duration of compression, the intraoperative balloon pressure, and the final shape of the inflated balloon were all independent predictors of treatment efficacy. The resulting multivariate model achieved an outstanding area under the curve of 0.89, offering a potential framework for real-time intraoperative feedback to ensure optimal balloon dynamics and maximize pain relief. In the realm of spine surgery, 2 papers in the Journal of Neurosurgery, Spine Challenge Conventional Approaches and Postoperative Assessment Paradigms. First, Yan and colleagues introduced a surgical paradigm shift for the resection of cervical dumbbell tumors, which typically require extensive posterior facet joint resection and subsequent instrumented fusion. The authors describe an outside-in lateral foraminal approach, using an incision along the lateral border of the sternocleidomastoid muscle, corridor creation through the interscalene space, and direct visualization of the vertebral artery and brachial plexus. In their series of 55 patients, this minimally invasive approach achieved gross total resection in 100% of cases while completely preserving facet joint integrity, thereby eliminating the need for spinal fusion. Patients experienced significant neurological recovery, with mean Japanese Orthopedic Association scores rising from 13.3 to 15.1, and visual analog scale pain scores dropping from 4.3 to 2.4. For patients undergoing lumbar spine surgery, we often rely on patient-reported outcome measures to gauge success, but a prospective multi-center study by Naruzi Gilandihi and colleagues reveals a major disconnect between what patients report and how much they actually move. Using a smartphone application to track objective daily step counts in 289 patients undergoing endoscopic lumbar decompression, the researchers found that while over 70% of patients achieved a clinically important difference in back and leg pain by 2 weeks, their objective step counts actually decreased significantly at this early postoperative stage. Step counts did not begin to increase until 3 months postoperatively, continuing to improve up to 1 year even though pain scores remained flat after the initial 2-week drop. Crucially, preoperative pain and disability scores did not predict postoperative physical activity, and postoperative pain scores did not correlate with daily step counts. Instead, the single best predictor of a patient's physical activity at 1 year was their preoperative step count. This highlights that pain relief does not automatically translate into immediate physical activity, and tracking objective step counts provides a distinct, independent measure of functional recovery that patient-reported questionnaires simply cannot capture. Our final theme brings us to the difficult decisions surrounding geriatric head injury and the integration of artificial intelligence in neuro-oncology. In Acta Neurochirurgica, Arhus and colleagues address the clinical dilemma of managing traumatic brain injury in patients aged 80 years and older. In a cohort of 608 patients with imaging-confirmed traumatic brain injury, only 14% underwent neurosurgical intervention. The overall mortality was stark, with 24% dying within 30 days and 42% within 1 year. While undergoing a neurosurgical intervention was associated with a roughly halved risk of death at 30 days, it did not translate into any survival benefit at 1 year, nor did it improve functional outcomes at 6 months, with favorable outcomes achieved in 29% of the surgical group compared to 34% of the conservative group. Notably, acute craniotomies carried the highest mortality, whereas delayed trephination for chronic subdural hematomas was associated with a low 5% mortality and superior functional recovery. Ultimately, long-term outcomes were dominated by pre-injury factors, including age, American Society of Anesthesiologists physical status class, and pre-injury independence. This underscores the need for highly selective, patient-centered surgical decision-making in the oldest old, focusing on baseline function and realistic goals of care. Finally, we look at the future of neuro-oncology decision-making. Writing in the Journal of Neuro-Oncology, Reyes and colleagues conducted a systematic review of 30 studies evaluating artificial intelligence, machine learning, and deep learning models for prognosis and treatment stratification in glioblastoma. Survival prediction was the most common task, with radiomics combined with conventional machine learning representing the most frequent model architecture. However, the authors sound a note of caution for clinicians. The current literature is highly heterogeneous, methodological reporting is inconsistent, and external validation was performed in fewer than 17% of the analyzed studies. While artificial intelligence holds immense promise for personalized glioblastoma care, these findings indicate that the technology is not yet ready for routine clinical translation, and future research must focus on rigorous external validation across diverse patient datasets. We also note a JAMA publication tracking trends in patient portal messages and clinic encounters, highlighting how digital communication continues to reshape the administrative landscape of modern clinical practice. If you only have time for one paper this week, make it the prospective study on pediatric ependymoma from the Journal of Neurosurgery Pediatrics. This paper is a powerful reminder of the fallibility of intraoperative surgeon assessment and demonstrates that routine, early central neuroradiological review, coupled with aggressive, safe reoperation for residual disease, can nearly double progression-free survival without increasing neurological deficits. Here are the key takeaways from this week in neurosurgery. First, in pediatric ependymoma, surgeons frequently misidentify residual disease as a gross total resection. Early central imaging review and subsequent reoperation are safe and significantly improve long-term survival. Second, late cerebrospinal fluid shunt infections occurring after 6 months are clinically distinct from early infections, are frequently associated with abdominal pseudocysts, and are often missed by standard cerebrospinal fluid cultures. Third, for elderly patients over 80 with traumatic brain injury, acute neurosurgical intervention reduces early mortality but does not improve 1-year survival or 6-month functional outcomes, which are primarily dictated by pre-injury baseline status. Fourth, patient-reported pain scores after lumbar decompression do not correlate with objective physical activity. Monitoring daily step counts via mobile health tools offers a more reliable and independent measure of true functional recovery. And fifth, while vagus nerve stimulation is highly effective for refractory epilepsy, the greatest reduction in seizure frequency and medication burden is seen in patients with low baseline seizure frequencies of 1 to 2 events per month or year. That's your roundup for this week in neurosurgery. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.